Now, let's move on to neural tube defects, or NTDs. These occur when the neural tube, which normally forms the brain and spinal cord, fails to close completely by the fourth week of development. This can happen if the mother has a folate deficiency or if she is exposed to certain teratogens, substances that interfere with development, such as valproate or carbamazepine during pregnancy. Doctors can diagnose these defects using ultrasound imaging or by measuring maternal serum alpha-fetoprotein, abbreviated AFP, and sometimes amniotic fluid acetylcholinesterase, known as FAIN, especially if the defect is open. Let's start with spinal dysraphism, which affects the spine. The first type is spina bifida occulta, which is a closed neural tube defect. Here, the caudal, or tail end, neural tube fails to close, but there's no herniation of tissue. The protective dura, which is the outer membrane covering the spinal cord, remains intact. This usually occurs at lower vertebral levels and can often be identified by a tuft of hair or a skin dimple over the affected vertebra. Next is meningocele, an open neural tube defect. In this condition, the meninges, the membrane surrounding the spinal cord, herniate through the bony defect, but the neural tissue itself stays in place. Then we have myelomeningocele, which is more severe. This is also an open defect, but now both the meninges and neural tissue, like parts of the cauda equina, actually protrude through the spinal opening. The most severe form is myeloschisis, where the neural tissue is exposed, unfused, and there's no covering of skin or meninges. Moving up to the head, we encounter cranial dysraphism. One major example is anencephaly, an open neural tube defect caused by failure of the rostral, or head end, neuropore to close. In anencephaly, the forebrain does not develop and the calvarium, or skull, remains open. This condition often presents with polyhydramnios, meaning excess amniotic fluid, because the fetus can't swallow properly due to lack of neural control. Depending on the type of defect, you might see different changes in the skin and surrounding tissues. In spina bifida occulta, the skin is usually normal, though a tuft of hair or skin dimple may mark the spot. In meningocele, a skin defect or thinning may be present. Myelomeningocele features thin or absent skin, herniated meninges, and exposed neural tissue. Myeloschisis has fully exposed neural tissue without any skin or meningeal covering. Brain malformations can also occur and are often incompatible with life after birth, and survivors may be profoundly disabled. One notable brain malformation is holoprosencephaly, which happens when the forebrain, or prosencephalon, fails to divide into two cerebral hemispheres. This is a developmental field defect that typically occurs between the third and fourth weeks of development. It's associated with mutations in the sonic hedgehog gene, SHH, and can also appear in Patau syndrome, which is trisomy 13, or in fetal alcohol syndrome. Holoprosencephaly often presents with midline facial defects. You might see a single ventricle in the brain, fused basal ganglia, cleft lip or palate, closely spaced eyes called hypotelorism, or even cyclopia, where there's a single eye, and proboscis, a tubular nasal structure. There's also a risk for pituitary dysfunction, such as diabetes insipidus. Another serious malformation is lissencephaly, literally meaning smooth brain. Here, neurons fail to migrate properly during development, resulting in a brain surface without the normal folds or gyri and grooves or sulci. Patients often present with difficulty swallowing, seizures, a small head known as microcephaly, and facial anomalies.